I'm going to talk about a topic that I've been talking for many years, about reduced drug regimens, what are the data, and since we are going to have some overlap with other presentations, and Pedro is coming right after me to talk about switch, I'm going to restrict my talk to naive, to dual therapy in naive, that, as I said, is something that I've been doing for many years. So this is a panorama of the guidelines. As Margaret mentioned this morning, there are consensus among the guidelines in two issues. One is triple therapy. You can see that no guideline at this moment recommend less than 3 drugs in antiretroviral naive patients, and these are 3 drugs are a combination of 2 nucleosides, reverse transcriptase inhibitor, and a third drug, and there is more and more consensus about the third drug being an integrase inhibitor. So this is the scenario we have. There is not a single guideline that recommends less than 3 drugs in antiretroviral naive patients. And to be a preferred regimen in antiretroviral guidelines, this is from the GESIDA guidelines in Spain, but this is very similar all over the world. If you want to have a preferred regimen, it has to be applicable to the majority of patients. In a randomized clinical trial, it has to show superiority over the comparator arm, or if there is a non-inferiority trial, you have to show non-inferiority, but then an advantage in terms of tolerance, toxicity, or interaction profile. So if you want to put these criteria in numbers, that means that you have to come with a clinical trial that shows that after 40 weeks, more than 90% of the participants are undetectable by FDA snapshot. You have to have really very few virologic failures, less than 1%. And we have to recognize that we live in an era of zero tolerance for resistance. So you have to show no resistance in the clinical trial. And also, the regimen has to be very well tolerated. You have to show less than 1%, 2% discontinuations due to adverse events. So we have tried for many years to reach this goal with less than triple therapy. And in general, this is a story of epic failures. You see here a decade of attempts to match the efficacy of 2 nucleosides and a third drug, with regimens in general in the past based on a boosted PI, taking advantage of the still uncomparable genetic barrier of boosted PIs with a second drug that could be an integrase inhibitor, a non-nucleoside, or an integrase inhibitor. And you see here is a busy slide with many attempts, but the message is very clear. Almost everything failed, and I'm just going to give you 2 examples based on the trials that have the largest sample size. And the first one is NIT-001. This is, until very recently, was the largest clinical trial in antiretroviral naive participants that tried to challenge the concept of triple therapy with the combination of darunavir-raltegravir. I was there when the trial was designed, and I can tell you that everybody thought in the room that this was going to be very easy. We have extremely potent high genetic barrier PI, darunavir-ritonavir, and we were really amazed about the potency of the integrase inhibitors, raltegravir, in studies of monotherapy for several days have a decrease, as we saw this morning, of almost 2 logs. So everybody thought it was going to work, darunavir, raltegravir compared with darunavir and TDF FTC. And the trial met the primary endpoint here with, you can see here the difference in the intention to treat in patients with treatment failure. The non-inferiority margin was 10%. It met the criteria for non-inferiority. However, and this has been a common finding in many of these nuke-sparing regimens or dual therapy regimen, when you focus on the participants most difficult to treat is where you start to see differences. And here you can see that in participants with more than 100,000 copies per ml, you can see that the dual therapy arm has 36.8% failure rate compared to 27.3% in the triple therapy arm. And you can see here that you clearly miss the non-inferiority criteria. You went up to 20%. And things become even worse in participants with advanced HIV with less than 200 CD4s. You can see here that the difference actually shows superiority of triple therapy with 2 nucleosides versus raltegravir and darunavir. To make things even worse, if you look at resistance development, you see here 18 participants from the darunavir-raltegravir arm, and you can see that 15 of them had developed integrase inhibitor mutation. And this is in very, very sharp contrast with what didn't happen in the triple therapy arm. Not a single participant developed mutations. So, as many times in science, our hypothesis was proved wrong. This, even with darunavir and raltegravir, was very difficult to match the efficacy of triple drug therapy, and the nucleosides maintain their terrain, and other attempts were performed after that. So then the modern clinical trial came up. It's also a very large clinical trial. This trial enrolled participants who were infected with CCR5 tropic viruses. They were very careful to do 2 tests to select only participants with R5 tropic viruses. And the comparison was darunavir TDF-FTC triple therapy versus darunavir and maraviroc. And you can see here the results at 40 weeks. You can see here that the non-inferiority is not met. The difference is 87% versus 77.3%. And you can see here the lower limit of the confidence interval misses the non-inferiority margin. Again, even with the primary endpoint, darunavir-maraviroc didn't match the efficacy of darunavir and 2 nucleosides. And again, the same thing happened when we look at participants with high viral loads. In this graph, this blue part is what favors triple therapy. This is what favors nuke-sparing dual therapy. You can see all the point estimates favor triple therapy, but the differences become, again, statistically significant in participants with less than 200 CD4s, and you can see also in participants with more than 100,000 copies per ml. Still, we don't have a very good mechanistic explanation why, all these regimens not containing nucleosides underperform in participants who are advanced or have very high viral loads. So this series of failures stopped after a new strategy was tried, that is based on the fact that if you cannot beat them, just join them, and then instead of taking out completely the nucleosides, keep one of the nicest nucleosides that we have, that is 3TC, and then came from Pedro Kahn's team this very disruptive trial looking at lopinavir-ritonavir 3TC versus lopinavir-ritonavir and 2 nucleosides. And to the surprise of many, I remember when Pedro presented this trial, you can see here that when we compare lopinavir-ritonavir 3TC and lopinavir-ritonavir and 2 nucleosides, these are 96 weeks results. Here you have dual therapy, 90.3% versus 84.4%. The trial met non-inferiority criteria. So when you see this slide, you are immediately after what I've shown you before, you are waiting for the results in high viral loads. And in high viral loads, actually, the results, more than 100,000 copies per ml, were extremely good for dual therapy. 82.87, I can't see, my side is 82% versus 77.9%. So, and there was not an increased risk of resistance in the dual therapy arm. So this is where very interesting results. I always make the joke with Pedro is the only smiley face after all this series of epic failures. This proves that when you have one nucleoside on board, you can match the efficacy, 3TC in particular, you can match the efficacy of triple therapy with 2 nucleosides. So because there are really, here, as you saw this morning, there are very strong opinions. People thought, well, this is with lopinavir, and many participants took Combivir, and this is not with, you will, you just have to compare with really nicer nucleosides. So Pedro presented also very recently a new iteration of this concept is the comparison of darunavir, ritonavir, and 3TC. This is a fixed dose combination. This is not from Janssen that they have in Argentina versus darunavir, ritonavir, and TDF 3TC, and actually this is a 145 study. You can see that the efficacy rates are of triple therapies 94% at 40 weeks versus 93%, and no difference again in more than 100,000 copies per ml. So until now, these are the studies that have been based on boosted PIs. But there was boosted PIs have their limitations because of the boosting. So there was an interest, as we saw this morning, when the integrase inhibitors came about with high genetic barrier to do trials with less than 3 drugs. And I think this is the example of very well performed dual therapy study with dolutegravir 3TCs. The paddle study, you've seen the slide many times in conferences, is really set up the stage to do larger trials because the results of these 20 participants were good enough to try this strategy. The next trial we saw about dual therapy with dolutegravir 3TCs, ACTG 5353. And I'm picking this study because it served as the phase 2 study for the Gemini studies, and this is a single-arm study. Participants is 120 participants who are treatment naive and less than 500,000 copies per ml at baseline. They were started on dolutegravir 3TC, and the main one of the main objectives of this trial was to see if there was an impact of having high viral loads above 100,000 copies or below 100,000 copies. And you can see here that in the study it appears that there was no impact of high viral loads in this combination. You can see here that there were 3 failures above about 100,000 copies and 2 failures below 100,000 copies. But what was worrisome, there was a very poorly adherent participant that developed resistance with dolutegravir 3TC with these 2 mutations, 263RK and 184B. So that was the stage that led us to what is going to be, what has been the biggest news in antiretroviral therapy during this year are the results of the Gemini trials that based on the results of PADL and in the results of ACTG 5353. Here there are 2, you saw an advance this morning in Margaret's presentation. I'm going to be showing with more detail the data. These are 2 identical phase 3 double-blind studies, multi-center, multi-country, and it's 1,400 patients. So it's very, it's the largest trials ever performed on antiretroviral naive patients with dual therapy. To be enrolled, you have to be antiretroviral naive. Obviously, you have to be hepatitis B antigen negative, and the viral load limit was up to 500,000 copies per ml. And as I said, this is double-blind. It's comparing dolutegravir 3TC versus dolutegravir and Truvada. These are the baseline characteristics. The is very similar to other recent trials of antiretroviral therapy. What you can see here, the take-home message is that 20% were above 100,000 copies per ml and around 10% were below 200,000 copies per ml. You've seen, and you are going to see many times, these results because I think it deserves a lot of attention because it's the first time that in antiretroviral naive participants we've seen high efficacy of a dual therapy not based on a boosted PI. And you can see in Gemini 1, the point estimate in favor of triple therapy is 2.6. It really meets non-inferiority criteria. And in Gemini 2, differences are even smaller, also meet non-inferiority criteria. And actually, Margaret also saw this slide. I want to show you to see it in another way. Actually, it's nice when you don't have to be a statistician to see that there are very little differences between two arms. But focus here. Focus on this is cool. This is shows here and here. So here, week 8. One might think that if you know you are using dual therapy, you can see a hint of less efficacy in the rate of becoming undetectable and how fast you become undetectable. But you see here at 8 weeks is 89%. You see if I see clear, 87 versus in dual versus 85 in triple. So you don't see a hint that participants in dual therapy are becoming undetectable is lower. So when you do this analysis, pool analysis, and you put, yes, basically you put both trials together, either if you use it by intention to treat that per protocol, that per protocols excludes participants that didn't meet all the inclusion criteria, again, non-inferiority is clearly met. So when Pedro Kahn presented this data in Amsterdam, everybody, and when we saw the data, also the trial team, everybody was waiting for a couple of slides. This, after what I've shown you before with high viral loads, what happened with high viral loads? What was the impact of high viral loads in the trial? Virtually none. There was no impact of, you can see here, that in participants with high viral loads, actually those on dual therapy, 92% undetectable, triple therapy, 90%. There was a bit of a surprise in low CD4 cell counts. You can see here that about 200 CD4 cells, there's the same efficacy. In less than 200 CD4s, there is a small number, but don't think this is very different, for example, from the Bictegravir trials. It's the same number of participants with less than 200. You can see clearly that there is a difference between triple therapy and dual therapy. So the question that immediately comes up, what is this difference related to virologic failures? Well, we did a type of analysis looking at the reasons for discontinuations. It's kind of complicated to explain. I think it's more it's easier to look at what were the reasons for this difference. And you can see here that there was only, here in the footnote, only one confirmed virologic failure. The other reasons were discontinuations due to adverse events, a participant with tuberculosis, a participants who have an adverse events with this nasty drug that is used to treat Chagas disease. There were 4 patients with viral loads above 50, 3 of these 4 resuppressed, and then you have here another 2 patients with protocol violations, 1 withdrew consent, and 1 withdrew due to hepatitis C treatment. But I think this is something that we still have to need more information. There seems to be a difference in participants with less than 200. We are going to be discussing about this for a long time, and I would love to hear your opinions then in the Q&A. What is also very important, one of the issues in the trial is that after what we saw in ACTG 5353 is if there was going to be virologic failures with resistance development. And you can see here that there were 6 virologic failures in dual, 4 in triple, and you see here this long row of zeros. There were not a single participant in which after virologic failure resistance development was detected. In terms of safety, as I said, I don't think in 40 weeks time is enough to show advantages when you're comparing with obviously with tenofovir difumarate, not TAF. You can see here basically numerically there was a slightly more adverse events in the triple therapy arm. None of the difference were statistically significant, but it's really difficult to tell. After 40 weeks, safety was very similar in both arms. What we've seen, obviously, when you compare with a TDF-based regimen, what we've seen, I'm going to be quick on this, is what we expected. Since you are not giving tenofovir at all, you see better results in terms of these soft endpoints of EGFR and these urine markers that we are quite used to see in the trials comparing TAF to TDF. We also saw advantages in these tubular function markers in favor of dual therapy. And also when we look at bone biomarkers, also favor dual therapy. And when we look at lipids, because you don't have the lipid lowering effect of TDF, also there was statistically significant differences in favor of triple therapy with TDF, although it's hard to see if these small differences will translate in clinical differences. So if you have had not enough of dual therapy, with dolutegravir 3TC here at Glasgow, there are interesting presentations. One of the issues is what happened with residual viremia when you don't use 3 drugs. You have here Babafemi Tai was going to present changes in residual viremia after switch to dolutegravir and lamivudine. Also viral decay with dolutegravir plus lamivudine versus triple therapy in naive patients. And also there is Chloe Orkin is going to present subgroup analysis of dolutegravir 3TC. So what is going to happen with guidelines after these results have been made public? So this is my pro and cons slide. What about this combination? It's an integrase inhibitor, so I think that's good because we are in the era of integrase inhibitors. No impact of high viral loads less than 500,000. No food restriction, is unboosted, has a good interaction profile. No resistance development. It's a good safety profile, very few discontinuation. And paradoxically, these results in naive patients also support a lot the use. If this works so well, even about 100,000 copies, it supports its use as a switch option. The cons is not an STR yet, but it's been, the FDA is already evaluating the single pill with dolutegravir and 3TC. There are clinicians also to want to know more granularity. We want to see if these viral loads of 100,000 are closer to 100,000 or to 500,000 copies. We're going to have long discussions about the issue of CD4s. Also durability, many people want to see 96-week data. This is not an option in chronic hepatitis B. It's not an option for test and treat. Although some people, after I saw this slide, come to me and say, well, this is a testable hypothesis that if you start a participant with 600,000 copies and you don't know about it, dolutegravir 3TC, and you see the results 1 week later, you can add a second nucleoside, or I would love to hear after that Jonathan's opinion about you can develop resistance to dolutegravir and 3TC in 1 week. But this is not the end. The end is what I call less than 3 phobia. You are going to see a lot of questions, and you are going to ask things that in general is less than 3 phobia when it's oral. When it's long-acting, it appears that goes away. But when you see 2 drugs, immediately people come to the microphone talking about inflammation, talking about reservoirs, talking about even if less than 3U equals U. That's something that we are going to hear. And then you are up against 30 years of triple antiretroviral therapy. So if they ask you that you have to show 30 years of durability with dual therapy, at least many of the ones who are here are not going to be here 30 years from now. Thank you.